Good afternoon, everybody. I am Dr. Sunil Narang from Delhi. I am primarily a vitreoretinal surgeon, and now I do everything: cataract, refractive surgery, and vitreoretinal surgery. Unfortunately, doing three things is backbreaking, but I love retina, and I have to do cataract and refractive surgery for survival. So today I'll be talking about a very controversial topic, that is LASIK and presbyopia. This we have been doing for the last 7-8 years, but in very selective cases. So controversy was that should we do it or not? Like most of us are not selling multifocal lenses, only if the patient asks for it and forces us for it. That's what I do personally. I don't sell multifocal lenses. I let the patient buy it. So my concept of pseudo-accommodative cornea is based on a French surgeon's technique. I was trained by him, Dr. Calendro. He's in Cannes, which is more famous for the festivals, film festivals. The aim of this treatment is to create emetropia in the center of the optic zone on the visual axis over a surface of 3.5 millimeters, and then gradually forming a peripheral zone for the near vision. That means periphery is used for the near vision and the center is used for the distance vision. This is a diagram how it works. The central yellow part is for the distance vision and the peripheral large optical hyperopic zone for the presbyopia. Now I will tell you our experience about the presbyopic cases. This is not all cases. We have more cases now. This is 126 cases. And average age of the patient is 49 years. And most of them, many of them are hypermetropes, less number myopes, and even lesser emetropes. This is the age distribution. So most of the patients fall in the age group of 45 to 50. This is the distribution of the patients: hypermetropes 68, myopes 32, and emetropes 26. And we have not done this procedure for more than plus or minus 4 diopters of error. I use NIDEC now. I use the EC 5003, that's a CX3. And at that, we are using Moria keratom. Recently, we have started using the femto flap for these because we get bigger flaps. And this is a multi-step focal ablation giving a pseudo-accommodative cornea carried in 3 stages. This stage 1 and stage 2 are the same actually. First is for the myopia. So first we treat the myopic error in 2 concentric zones, 2 large concentric zones. Large means 5.7 and 5.5, 7.5. And then we treat the hypermetropia, that means presbyopia, over the whole cornea, that is 6.5, 9.5 zone. And then, because of this treatment of hyperopia, there is an induced myopia. Then we again treat that myopia in the center of the cornea. Now, these are a few examples of hypermetropia. If you look carefully, here the OPD map is showing error of 5 plus 5 diopters. And after the treatment, you can see the concentric rings, which are concentric rings, and you see the post-operative error is nearly 0. Similarly, in this case, other eye of the patient, 2.53, and the post-operative nearly 0, and you can see the accommodative rings, the concentric rings in the center. Next one is the case of myopia. This is the first, that is minus 5 and nearly 0 after the treatment, and the rings, similar rings as we see in the hypermetropic eyes. Same here, this is the map 1 and 3. This is 1, minus 5, and after treatment is nearly 0. This is a emetrope case. He remains 0 even after the treatment. After the treatment, here there is a slight reduction of error, that is minus 1 diopter. Now, most of the patients' satisfaction level in group A, they are the most satisfied patients, that means hyperope patients, as in all refractive surgeries. And the least satisfied are the emetrope because they have crystal clear vision for the distance. Now there are some aberrations induced by the LASIK, so they get little dissatisfied for the distance vision. Now retreatment, we have done few retreatments also. And the complications, actually there are no complications there, as in the conventional LASIK. Distance vision usually settles for 2 months. Post LASIK, near vision, there is no overcorrection for blood pressure because we always treat plus 2.75 for all the patients. But there are few concerns. Concerns are not different from the regular LASIK patients. That means we need a large separation zone, that means 6.5, 9.5, which is not really achievable by any of the keratomes, even by the femtosecond laser. Loss of contrast sensitivity, that efficacy of near vision. We have noticed that efficacy of near vision goes down in next 3-4 years. And results are not really very predictable. And then the stability, because I've told you already that this is not very stable. 3-4 years, 4-5 years, 20% of patients, they have come back for the retreatments. This is one example of retreatment. This patient had an error of 2.7, 2.5 pre-operative, and post-operative it remained 1.75. And in the other eye also, this was 2.25 and post-operative remained 1.5. That means the treatment which was done at the end for the reversal of hyperopia induced by the presbyopic correction was not complete. And here also, this is one of the patients where the residual error was minus 1.5. Then we did the treatment and it became 0. This is the next map. So to summarize, patients are really very happy on the first post-operative day because the near vision is wow. This is very good. And achievable pseudo accommodation is about 2 diopters. This is more efficient in hyperopes, but there is a key role of positive spherical aberrations, which probably we have induced by this treatment. And this is an interesting option for high myopes, although we have not taken very high number of high myopes. Multi-zone LASIK is as effective as conventional LASIK for distance correction. There is a loss of some contrast sensitivity as in all other LASIK patients. Patients have some glare in the night vision initially. We have been refining the nomograms continuously and we are still worried about the long-term stability. And we need large number of patients to assess. So what about our problems is inconsistency of results in the first year, and then after 4 or 5 years they come back for the retreatments about 20%, and there is a requirement of large ablation zone and stage of demyelinization. We have done few modifications. I will just tell you very short. So we have reduced the zone of hyperopic correction from this 10 to 9.5, and the demyelinization from 4.0, 5.0 to demyelinization means central neutralization of the corrected induced hyperopia to 4.1, 5.1. This is a very slight difference, but it makes some difference because it goes more than 8 microns now, which I feel is the minimum to have effective correction. And we have started performing PTK after every hyperopic treatment. But still, prerequisites is motivation, counseling, patients counseling, and I tell you that in spite of the absolutely perfect counseling by me personally, still patients are in fighting mode after 2-3 months. They come for fight actually. They have been told already that you will need retreatment, and the patients on the part of the patients. And we have been refining these nomograms continuously according to the previous patients, previous series of patients, previous few patients. But still there is a lot to be achieved, and still we have not reached the perfection stage. Thank you so much.